All right. So with Dr. Brinton, we are at the quorum. So thank you for coming to the DUR board meeting today. As a few reminder for our meeting today is if you are dialing in via telephone, Google Meets have muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please preserve your question until the end of the presentation or ask in the Google Meet chat. Public comment, if you would like to provide a public comment, COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or send in the email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you very much. With that, I will leave this to Dr. Cannon. Eric, you are on mute.
Yeah, I figured that out. You'd think after this long. Anyway, good morning, everybody, and welcome to the DUR board. So I will call this meeting to order, and it does look like we have a quorum. So we will move ahead. In terms of housekeeping, it is time to nominate a new chair of this lovely committee. So, Noon, do we open that up for nominations?
Yes. If anyone have any nomination.
Normally we wait 8 seconds and move on, but Kumar?
Can I propose that, Eric, if you would consider continuing for another year?
I would consider that.
So
if you all could stand me doing it again.
So that's my I'm nominating Eric Cannon.
All right. Do we have additional nominations? All right. Hearing none, and then out of the sake of continuing this meeting, all in favor of Kumar's nomination?
Aye.
And any opposed? We will pay for opposition. All right. Hearing none, I will relate to all of you a very, very brief story. About a year ago, my wife and I have been looking for 5 years for some property in Holiday to build a home. We currently live in Holiday, but we're building a new home, or wanted a home to retire into. And we ended up buying a piece of property not far from our home, but which was owned by an individual that probably many of you know, Dr. Lowry Bushnell. And so Dr. Bushnell will actually be my neighbor. He lives to the west of me. He and I were talking the other night, and any of you that may know him, he went to pharmacy school before he went to medical school. But we have this conversation typically every time we get together. But he told me the other night, as we were standing there looking at a big pile of dirt, that his favorite thing he had done in his career was to chair the DUR board. And I kind of started to laugh and said, I think maybe you've got a bad memory. So anyway, with that, it was a fascinating story, I'm sure, for all of you. And I apologize for boring you, but let's move on. You all should have received a copy of the minutes. Do we have any comments, corrections, or suggestions on the minute? Kumar?
May I propose that we accept the drafted minutes as presented?
All right, we have a motion to accept and approve. Do we have a second?
I'll second. This is Michelle Hoffman.
Thanks, Dr. Hoffman. So we have a motion and a second. All those in favor of approving the minutes?
Aye.
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 All right, any opposed? Okay. With that, was there a comment? It's not. With that, Brian, we'll turn it over to you for a P&T update.
Before the P&T update, we have one more housekeeping item.
Oh, okay.
Lisa, Lisa, would you like to introduce yourself? Lisa is our new pharmacy director.
Yes, Lisa, thank you.
I would love to introduce myself. Hello, everyone. Thank you for your time and dedication to our DUR board meetings and these processes. I'm Lisa Angelos. I recently started as the Medicaid pharmacy director. I'm excited to be here. I have past history working for 10 years with Intermountain Medical Center, just to give you a little background, and 10 years prior to that working with the Medicaid Drug Regimen Review Center, where that's the place where I realized that I had a passion for helping to care for the Medicaid population in our state. And so I'm excited to be back here and able to serve our Medicaid members with all of you. So thank you so much.
Thank you, Lisa. We're excited to have you on, and hopefully this runs smooth, so this isn't the bane of your existence. So moving forward, we good now, Noon? Can we go to Brian?
Yes.
Okay, Brian, P&T update.
Thanks, Eric. In September, the P&T committee met and we discussed sedative hypnotics, non-benzodiazepine, non-barbiturates, and no significant changes there. And then we won't have a meeting this month. So our next meeting will be in February. And that's all I have. You're on
You
mute.
are on mute.
Kumar, we'll turn it to you.
Yeah, so I have a question. So at the next meeting in February, what's the main agenda item? That's for Brian.
Yeah, just a second while I pull that up. In February, we were planning to discuss the we were talking about the anti-VEGF products, but I think we're actually going to be doing the non-stimulants for ADHD. I'll have to double check my records on that, but I think that's what we're doing.
All right. That we will turn this over now to the University of Utah to talk about the new CDC guidelines for the treatment of sexually transmitted diseases.
Okay, I will take that away. Just give me 1 second. Okay. Good morning, everybody. Today, I will be reviewing the recommended pharmacologic treatment or prophylaxis for sexually transmitted infections, abbreviated STIs, and vulvovaginal candidiasis, according to the 2021 CDC guideline. The treatment of HIV and viral hepatitis were considered outside the scope of the CDC guideline. I'll highlight the Utah Medicaid preferred drug list status of the CDC recommended patient-administered therapies. Based on data from 2018, the CDC estimated that approximately 20% of the US population had an STI. In 2018, there were 26 million new STI infections among people in the US, with nearly half occurring among adolescents and young adults aged 15 to 24 years. STI treatment goals include resolving the infection or symptoms and preventing the spread to others. Individuals with an untreated STI are at increased risk for severe complications and transmission of the STI to others. This table shows the STIs reviewed in the 2021 CDC guideline, organized by the type of causative pathogen. For the sake of brevity, I will only review in detail the guideline recommended treatment regimes for the STIs outlined in red, because these infections are the most prevalent among the respective pathogen group. Most of the STIs that I mentioned during the presentation have updated recommended treatment regimes in the 2021 CDC guideline compared to the previous guideline iteration published in 2015. The CDC STI guideline did not provide evidence ratings for their recommendations. Treatment regimes were categorized as recommended or alternative in the guideline. Recommended regimes should be used for the majority of cases unless contraindicated. Alternative regimes were considered inferior to recommended regimes, but can be considered when use of a recommended regime is not advisable. Alternative regimes are not provided for all STIs. This presentation primarily focuses on recommended treatment regimes. Please refer to the report for details regarding alternative regimes. In the US, chlamydial infections are the most commonly reported bacterial STI, with the greatest prevalence among individuals less than or equal to 24 years of age. Patients are commonly asymptomatic. Presumptive treatment should be provided to all sex partners within the previous 60 days prior to symptom onset or diagnosis, and to mothers of neonates or infants with certain types of chlamydial infections. All recommended regimes for chlamydial infections are taken orally. Doxycycline is an effective treatment for infections in the urogenital, oropharyngeal, and rectal regions, and is the preferred agent among adults, adolescents, and older children. Azithromycin is the preferred agent during pregnancy and for young children. Erythromycin ethylsuccinate or base is recommended for neonates with certain types of chlamydial infection or for infants and young children weighing less than 45 kilograms. Gonorrhea is the second most prevalent bacterial STI in the US. Presumptive treatment should be provided to all sex partners exposed within 60 days prior to symptom onset or diagnosis, to mothers of neonates with a gonorrhea infection, and newborns at high risk for infection due to an untreated mother. Ceftriaxone is the only antibiotic considered highly effective for gonorrhea infections. The medication is given as a one-time intramuscular dose for uncomplicated infections in adults, adolescents, and in children weighing more than 45 kilograms. If a disseminated infection occurs in adults or adolescents, hospitalization and treatment with daily doses of intravenous or intramuscular ceftriaxone is recommended. In the US, reports of gonorrheal conjunctivitis in newborns is rare, likely due to most states mandating ocular prophylaxis with erythromycin for all neonates. Ceftriaxone regimes are also recommended for treatment among populations not mentioned in this table. Please refer to Table 2 in the report for details. Pelvic inflammatory disease, abbreviated PID, is an infection that involves the upper reproductive tract of females and may extend into the pelvic region. An estimated 50% of acute PID cases are caused by chlamydia and gonorrhea, and the risk of developing PID from these infections is decreased when they are treated early. Presumptive treatment is warranted for women at risk for an STI or those who are sexually active, who have lower abdominal or pelvic pain, no other explanatory etiology, or tenderness of the cervix, uterus, or pelvic region on physical examination. Treatment regimes consist of broad-spectrum antibiotics primarily administered intravenously or intramuscularly, depending on disease severity. Oral administration is available for some agents included in both IV and IM regimes. IV therapy should be considered for women with severe presentations who are pregnant or fail to respond to a recommended intramuscular and oral regime within 72 hours of initiation. Intramuscular and oral regimes can be considered for the treatment of mild to moderate acute PID. Recommended treatments include a second or third generation one-time IM cephalosporin combined with oral doxycycline and metronidazole for 14 days, as shown in this table. The 2021 guideline was updated from the 2015 guideline to recommend that metronidazole be part of all regimes for the treatment of mild to moderate PID. The updated recommendation to use metronidazole with doxycycline was based on the therapeutic benefit of anaerobic coverage to prevent long-term sequelae associated with PID. This is an overview of the agents grouped by route of administration that were recommended as part of a regime for the treatment of at least one bacterial STI by the CDC guideline. For a given infection type, the recommended regime generally depends on age, sex, causative organism, comorbidities, and stage of treatment. The recommended dosage form varies by infection type and availability. Notably, some agents may only be recommended for the treatment of one bacterial STI, whereas other agents may be used for the treatment of multiple bacterial STIs. In addition, an agent may be recommended for use only in a certain patient population. For additional details, please refer to Table 1 in Appendix A. The acquisition of some viral STIs can be prevented with vaccinations. Recommended vaccinations were from the ACIP guidelines as shown on this slide. Refer to the most recent ACIP vaccination schedules for details. Notably, regarding the treatment of viral STIs, the CDC guideline recommendations only cover treatment of clinical manifestations of HPV and HSV infections. The development of anogenital warts may occur months or years after the initial inoculation with HPV. Available treatments may temporarily eradicate the appearance of warts, but most likely do not eliminate the HPV infection. The 2021 CDC STI guideline provides a variety of topically administered preferred options for the treatment of anogenital warts, either applied by the patient or administered by the clinician. An individualized shared decision approach should be implemented to determine the best treatment for the patient. Patient-applied topical medications should only be used for external anogenital warts. A trained physician should execute the treatment of internal warts. Genital herpes is a permanent chronic infection of herpes simplex virus 1 or 2 and is managed with oral acyclovir, valacyclovir, or famciclovir. All three of these antivirals are an option for most populations. One exception is that famciclovir is not a recommended option as daily suppressive treatment in pregnant patients. It is recommended that all patients presenting with an initial episode receive presumptive treatment regardless of symptom severity. Duration of therapy varies according to whether treatment is for an initial episode or a current episode or for suppressive treatment. Refer to Table 4 of the report for additional indicated populations in which these antivirals can be used, including people with HIV and who are pregnant. This slide summarizes all the agents among guideline recommended regimes for the treatment of genital herpes and genital warts. No alternative regimes were provided by the guideline. Trichomonas is a sexually acquired infection that results from exposure to a protozoan parasite. In 2018, the CDC estimated more than 2 million people were infected within the US, with the majority of individuals asymptomatic or with minor symptoms. CDC recommended treatment options include metronidazole, either as a one-time dose or twice daily regime for 7 days, depending on the population, or tinidazole for women with treatment failure. Metronidazole is the preferred option during pregnancy. Notably, while the 2015 CDC guideline recommended the same single-dose regime of oral metronidazole for men and women, the 2021 guideline changed the recommendation to favor the multi-dose 7-day regime for women. This is a summary of agents used in the CDC recommended or alternative regimes for the treatment of parasitic STIs, including Trichomonas, pubic lice, and scabies. The RR represents that particular agent as part of a guideline recommended regime, whereas AR signifies that the agent is part of an alternative regime. The 2021 CDC STI guideline also provides guidance on the treatment of vulvovaginal candidiasis, abbreviated VVC. Treatment of this condition was provided in the guideline due to the high prevalence among women either at risk for an STI or who experience vaginal symptoms that tend to coincide with some STIs. VVC is primarily caused by Candida albicans, but can also be caused by other species of Candida. In the US, VVC results in approximately 1.4 million outpatient visits per year. This table shows the guideline recommended treatment options for VVC, which can be used in uncomplicated or complicated cases. Longer durations of treatment are recommended for complicated cases. Treatment options include over-the-counter prescription antifungal agents. The majority of recommended treatment options are administered intravaginally, whereas there is only one oral option, fluconazole. We reviewed the status of patient-administered oral or topical agents that are part of the CDC recommended regime on the Utah Medicaid Preferred Drug List, or PDL. The majority of guideline-recommended oral or topical antibiotics for the treatment of bacterial STIs are preferred on the PDL. A few recommended oral agents are not included on the PDL, including azithromycin and erythromycin, ethylsuccinate, or BACE, but we have been informed that these agents are accessible via open access, meaning that they do not require a prior authorization or have any restrictions. It is unclear if having products absent on the PDL causes confusion for clinicians, as one may interpret such product as not covered. For the treatment of genital herpes, oral famciclovir is non-preferred on the PDL, but other CDC recommended agents for treatment, including oral acyclovir and valacyclovir, have PDL preferred status. Imiquimod, a recommended topical option for the treatment of HPV genital warts, is PDL preferred, whereas podophylax and spinacatechins are open access but unlisted on the PDL. For the treatment of scabies, oral ivermectin is not listed on the PDL but is accessible via open access, and ivermectin lotion is non-preferred. Another recommended option for scabies, permethrin 5% cream, is PDL preferred. Permethrin-based OTC options, including the 1% liquid and lotion, are covered, but it is unclear if these covered agents include the guideline-recommended formulation for the treatment of pubic lice, the 1% cream rinse. For the treatment of VVC, a few guideline-recommended products are non-preferred on the PDL or not covered, or not on the covered OTC list. OTC, miconazole vaginal suppositories, and teoconazole ointment are not covered. In addition, intravaginal prescription products, teraconazole cream and vaginal suppositories, and butaconazole are non-preferred. Nevertheless, a few other recommended options for intravaginal or oral use are covered OTCs or preferred prescription products on the PDL. Overall, our comparison of the CDC guideline recommended oral or topical products for the treatment of STI and VVC infections among major populations to PDL covered products found that at least one guideline recommended initial agent is accessible either as a PDL preferred prescription product or a covered OTC. The Utah Medicaid Drug Utilization Review Board may consider continuing to ensure patients have access without requiring a prior authorization to at least one recommended patient-administered regime for the initial treatment of each STI. In cases where a topical and oral agent are included as recommended regimes for the same infection, consideration can be made for continuing to ensure both formulations are accessible. This concludes the presentation. Please let me know if you have any questions. Thank you for your time and attention.
Thanks, Monet. Dr. Hoffman, I saw you had your hand up and then you took your hand down. So did your question get answered?
Dr. Hoffman just left the meeting.
She just left the meeting, so maybe her question didn't get answered. So can I ask one question? Because just recently this week, I think even in the last couple of days, an email went out from the Department of Health on the treatment of partners. And I didn't really see any recommendations on the treatment of partners listed here, and wondered how what you presented coincides with what went out in email to all the licensed professionals this week.
Yeah, I did. Yeah, I did take a look at that, and I did see the recommendations that they put out on those forms, and it did coincide with what I had written within the report itself. The presentation didn't focus on partner treatment itself, but I did mention some presumptive treatment for sex partners in regards to gonorrhea and chlamydia in the presentation. But
okay,
yeah,
great.
These did coincide with what was in the guideline and consequently in the report.
So Noon, or even Lisa, I mean, they did call out several products that are not preferred or not covered that are recommended treatments. Several of which are generic. Is there a reason for that? Or are they just not on the federal list of covered drugs due to rebates, or how does that work?
I'm sorry, Eric, can you repeat the question?
Yeah, and maybe Monet can go back to the slide, but there were several kind of recommended OTC treatments that are not covered.
Yeah, for the presentation, the main OTC products that weren't covered related to the treatment of PVC, which the guideline does cover, even though it's a non-sexually transmitted infection. But I believe the other over-the-counter options for the treatment of the STIs that the guideline address are covered. The only question that was unclear was for the treatment of scabies, where on the OTC covered list, they do have the 1% liquid and lotion permethrin OTC formulations, but we were just unclear if the 1% cream rinse was included in those formulations.
Give me 1 second, I can take a look at that. Or if you know, Brian.
Let's see, on the prescription treatments for scabies and the scabicides and pediculicides, we do have permethrin preferred, and we also have coverage of non-preferred products through a prior authorization. We have permethrin, atroba, and vanillase is preferred among the prescription products. And the OTC products, let me just take a look. We have the permethrin 1% liquid and lotion. Does that answer the question?
Yeah, I think so. But I guess the question I still have in my mind is this a situation where it's better to not have some treatments that require prior authorization, where ultimately my guess is you've got a lot of physicians and even some patients that aren't going to go through that process?
Right. We don't have a lot of utilization on the scabicides and pediculicides. Whether or not someone's going to go through that process or not, I don't know. For a non-preferred, for other treatments for STIs that are not listed on the preferred drug list, when the drug class is not part of the PDL, that does not mean that they're not covered. It just means we're not preferring one product over another, so it's open coverage, generally speaking, as long as it meets the CMS definition of a covered outpatient drug.
Okay. So I will assume at this point that it's not an issue. And was there a motion or anything needed noon from the committee, or was this more informational?
This is more like informational and based on the recommendation from the DRC. There wouldn't be any much change to the coverage either, as most of the at least one guideline recommended patient administered topical or our agent is covered by our current policies right now.
Okay, great. Other questions from the committee? All right, hearing none, we will move on. Noon, it looks like you're reviewing the prior authorization for Spravato.
Yes. Before the PA review, there is some Spravato approval and denial rate that I would like to share with the board. So this is the Curida will pull from November 3rd of 2021 until November 3rd of 2022. We have a total every PA that we have on the Curie is 1,681 PA, but those PA including other determinations such as not eligible, more information needed, and admin closed for various reasons. And duplicated PA. So overall, the only PA that I calculated for the approval and deny is only 482 PA. And within that, we have 64%, 64.5% of approval rate and 35.47% of the denial rate for the Spravato. Any questions regarding the Spravato approval and the denial rate for Spravato?
You wouldn't happen to know the main reasons for denial, would you?
So the reason for the denial is mainly because it doesn't meet our criteria, which will be go over in a minute with the prior authorization. And the other one is probably because the provider didn't submit all of the information that we needed. We do have like a few of the PA that is, we have been trying to outreach to the provider for additional information, but didn't submit it to us on time. So we have to let it lapse and deny.
All right, was there, within the prior authorization, I guess where I was going is there one specific criteria that is more predominant as the reason for denial than another?
Yeah, we can go over that like right now.
Okay.
So on the screen, on the Word document on the site is the new PA criteria that we proposed to the board. And on the PDF is the old criteria that we are having published right now on our website. So some of the main change is I'm going to go over the new one is qualified diagnosis managed by or in consultation, patient-specific prescriber to specialist communication to discuss treatment option with a psychiatrist or mental health specialist qualified in the diagnosis and treatment of neuropsychiatric disease, have to be certified, a licensed scope of practice with prescribing authority for the diagnosis of treatment-resistant depression or depressive symptom observed with major depressive disorder with an acute suicidal ideation or behavior. We also requiring the new baseline depression assessment score utilizing a validated depression rating scale, scale name in the score. And another criteria that we are making a proposal to is requiring a failure up to antidepressant with at least 2 different classes up to maximal indicated doses, but no less than the commonly recognized minimum therapeutic doses, each used for more than 6 weeks unless clinical significant adverse effects are experienced or are contraindicated, such as SSRI, SNRI, TCA, pyrobion, mirtazapine, or a failure of 2 of the following antidepressant augmentation therapy, each used for more than 4 weeks unless clinical significant adverse effects are experienced or all are contraindicated, is a second generation of antipsychotic used in conjunction with oral antidepressant at up to maximal indicated doses, but no less than the commonly recognized minimum therapeutic dose. Requiring the provider to plan to monitor and manage the black box warning associated with Spravato, plan to administer in healthcare setting under supervision of a healthcare provider, observe patient for at least 2 hours after administration and advise no driving or use of heavy machine for the remainder of the day following the RAM requirement of the Spravato. This is a dosing Spravato that we require the provider to fill out. For the re-out criteria, update letter of medical necessity or update chart note demonstrating positive clinical response, update depression assessment score utilizing the same validated depression rating scale as above, re-evaluation by or in consultation with the mental health specialist or psychiatrist with a prescriptive authority, and continue to use in conjunction with an oral antidepressant as up to maximal indicated doses, but no less than the commonly recognized minimum therapeutic doses, and then the request dosing. So as to answer your question, Eric, the most denial that we see is the failure up to antidepressant from at least 2 different classes. Some of the requests that we receive that the patient hasn't tried or missing the dosing that they have tried before, or the detail why the patient wasn't be able to complete the therapy for more than 6 weeks. We do outreach on those to find out what's happened with the patient during their previous trial with the antidepressant.
Okay. And then do you, are ketamine infusions covered?
Like Spravato infusion, like ketamine, regular ketamine IV.
Yeah.
That should be off-label because it's not FDA approved, I believe, at this time for major depressive disorder.
Okay. Yeah. And I mean, I was just asking because, you know, there's several clinics around town that are doing this. Some only offer the nasal spray, but others are doing both. And so the ketamine would not be approved.
Well, just for clarification, we do not have a prior authorization on ketamine. And so whether or not a provider is using it on label or off label, we don't know because we don't have a specific prior authorization for medical coverage of ketamine.
Okay, no, thanks, Brian. That's helpful.
And in addition, ketamine is used for chronic pain as well as depression. So it's, you know, difficult to parse out what it's being used for.
Yeah, no, great. Thank you.
I did have a comment that you may, or suggestion that you may want to add to the criteria of approval, just at the very start, is that they should have already enrolled the patient, provider, and pharmacy in the REMS program, because it doesn't make sense to submit a prior authorization if you don't already have the REMS certification to administer the to obtain and administer the medication. I thought that might be important. And under the section that plan to administer in healthcare settings, at least with the ketamine and lidocaine infusions, for example, done at the pain management center, you have to have a driver or some means of getting home. Just to say advise no driving, I don't think is strong enough, because, you know, the person may then feel that they can, you know, drive home. But I would leave that open to comment.
No, and Susan, I think both of those are very good comments, because it doesn't make any sense to approve anything if they haven't been put in the REMS program. And, you know, making a stronger statement about having a driver, I think, is important.
Thank you for that. We will take that back, and I will take that back, and we can revise that to make it like stricter, to add those REM requirements to the PA.
And with the driver, it doesn't necessarily mean they have to have, you know, a person there. It could be public transportation, but just that they are not driving. And the person doesn't have to stay there the entire time either while they're receiving the infusion.
Catherine?
Could you just change the word advise to require and then let them figure out how to enforce that?
That
All right,
actually makes sense.
Go ahead, Dr. Siegfried, sorry.
Well, that actually makes sense to require no driving and advise no use of heavy machinery for the remainder of the day.
Okay. Other comments? Suggestions? All right, so what we have is the proposed form with changes to require no driving, whether they have a driver or using public transportation, and require enrollment in the REMS program. We don't have, are there other comments? So I'm assuming, Noon, you had written action on the agenda, so I'm assuming you need our approval of this. Do we have any motions? Kumar?
I suggest with the changes, this should be approved.
Great. We have a second.
Second.
Thank you. All in favor? Aye.
Aye.
Any opposed? All right, that provides the approval of the criteria with the suggestions and adjustments, changes. And with that, we will see, we have a meeting on the 8th of December. Anything else before we have a motion to dismiss? Noon?
Yes, the next meeting will be about the Auvelity.
Okay. Can I make one request that if we are going to look at prior auth criteria, can that be sent out to us on the committee beforehand?
Yes, I will try my best to send it about a week or at least before the meeting. It's at best as my possibility. We just need to make sure that all of the change is updated the change before we send to the DUR. But I will try my best. Thanks.
Yeah, no, thank you. And part of that is sometimes I can't see the screen. So that's more a personal request, so I can open my own copy here. So with that, do we have a motion to dismiss?
So moved.
All right. We have a motion and a second, and we will see everyone on the 8th of December. Everyone have a wonderful Thanksgiving, and we will meet up in between Thanksgiving and Christmas. Thanks, everybody.
Have a great day.
Can you hear me?
Yes.
Sorry, Eric. I've been on the whole time. This is Michelle Hoffman. I just got kicked off Google Meet a couple of times, and so I've been on the phone. Just to note that for the voting and all of that.
Great. Thank you.
And Dr. Hoffman,
All right, thanks.
sorry, you have a question earlier, and we missed your question.
I didn't actually have a question. My Google Meet was being really wonky on my phone as I was transitioning to my car to drive to the office. So sorry about that. I had no questions. Eric, I'm glad you brought up the partner treatment piece and that there was a robust discussion about that. So I appreciated that. Thank you.
Yeah, no, and it was a wonderful piece that went out. I thought it was very well done. So thanks for sending that out. And Dr. Joe Busby, we will need a snow update from Brighton on the 8th of December. All right, guys. Thank you.
Thank you. Bye-bye.
Have a wonderful holiday, everyone.
Thank you.